Hi, this is Michael Autos, and we are continuing our series on anesthesia and the endocrine system on Barish chapter 46, and this is lecture number 3. So we've talked about the adrenal cortex, and now we're going to discuss the adrenal medulla. Here's a chart that discusses the synthesis of various catecholamines, starting with tyrosine, which is converted into dopa by means of the enzyme tyrosine hydroxylase, which is the rate-limiting step in this whole process. And that's something I've seen on board exams before, so you should probably be aware of that. This goes to make dopa, which converts to dopamine, which converts to norepinephrine, which converts to epinephrine. And so we see all of our catecholamines in this chain of synthesis. These substances are then broken down by a combination of two enzymes, MAO, monoamine oxidase, and COMT. These enzymes lead to metabolites that include norepinephrine and medinephrine, as well as vinylmalonic acid, VMA, which is something that classically is found in the urine of patients who have a pheochromocytoma. So let's talk about pheochromocytoma for a few minutes. A few trivia facts. Remember the rule of 10%, which says that 10% of pheos are bilateral, 10% are extraadrenal, 10% are malignant, 10% are familial, and 10% found in kids. The symptoms of a pheo are paroxysms of hypertension, sweating, and headache. This is really the classic triad, and that's why I've put it in bold here. But there are many other symptoms, which might include orthostatic hypotension, palpitations, tremor, sweating, glucose intolerance, and weight loss. Classically, pheos were diagnosed by a urine VMA level, which was the most specific. You can also find epi and norepi in the urine. And the most sensitive test is an abdominal CT scan. And a lot of pheos are picked up incidentally on CT scan. What are the anesthetic considerations for patients with a pheo? Preoperatively, these patients need to have their uncontrolled sympathetic situation medically managed, and that's usually done with alpha blockade, drugs like phentolamine, phenoxybenzamine, or perhaps doxazosin. The goal is to restore the patient's plasma volume because their chronic hypertension usually leads to some volume contraction, and this is done by counteracting the vasoconstriction of the secreted epinephrine and norepinephrine. Beta blockade is usually added to their management in the form of propranolol or metoprolol, and this helps treat any persistent arrhythmias or tachycardia. Remember the principle of alpha blockade before beta blockade, the idea being that we don't want to give a beta blocker which actually weakens the heart while they still have a lot of afterload tone. That could precipitate an episode of acute heart failure with a weakened heart pumping against a high blood pressure. The textbooks say that you should treat these patients for a minimum of 10 to 14 days, and your goals are really to get blood pressure well controlled, get them volume expanded, and get their tachycardia and their PVCs under control. And if these goals haven't been met, many would suggest that you postpone surgery in order to get them properly optimized before having the surgical resection. Intraoperatively, our main concern is release of catecholamines, and this can occur not only with tumor manipulation or infarction if blood supply is compromised, but even during stressful moments like intubation or incision. And so we want to be prepared to manage these paroxysms of catecholamine release. An A-line is definitely recommended, and some say it should be put in prior to induction of anesthesia. And a CVP is often placed not only for invasive hemodynamic monitoring, but also for administration of vasoactive substances. People have described blood pressure control with a wide variety of substances, including nitrates like nitroglycerin and sodium nitroprusside, calcium channel blockers like nicardipine and probably clofidipine, and even magnesium sulfate has been used. We certainly want to avoid drugs that cause release of histamine. And in general, our goal is to use as many direct-acting substances as possible. So phenylephrine would be preferable to ephedrine in cases of hypotension. Halothane should be avoided, because of catecholamine-induced arrhythmias in the setting of the patient secreting a lot of epinephrine. And remember, if bilateral resection is planned, then the patient will need stress dose steroids because they will no longer have the ability to secrete glucocorticoids from their adrenal cortex. Postoperatively, we most commonly see hypotension now that their catecholamine secreting tumor has been released. But there can be residual tumor, and so we should be on the lookout for additional paroxysms of catecholamine secretion. Patients may also have renal injury, and we should be watching for that. And many of these patients develop hypoglycemia. We'll pause here for a moment in case you have any questions. You can make note of them and send me an email or bring the questions to class. Now we're going to talk about the pituitary gland. The pituitary actually has two separate compartments, two separate parts, which are embryologically distinct. The anterior pituitary is responsible for secreting many hormones, including prolactin, growth hormone, FSH and LH, follicular stimulating hormone and luteinizing hormone, TSH and ACTH, as we have already described. These are all secreted in response to a signal from the hypothalamus, which comes to the anterior pituitary. The pituitary secretes these hormones and they go to their final target. And patients can have hypersecretion of any of these hormones due to a pituitary adenoma, although I should remind you that some pituitary adenomas are non-secreting. And in those cases, patients may present not with endocrine symptoms, but with neurologic symptoms, so headache or visual changes due to the proximity of the pituitary gland to the optic nerve. The posterior pituitary gland is responsible for secreting vasopressin and oxytocin. And actually, these hormones are synthesized in the hypothalamus and are transported to the posterior pituitary, which is then responsible for secreting them into the circulation. A few specifics that we want to discuss. First is growth hormone. And patients who secrete growth hormone have acromegaly. Things we want to be concerned about are airway concerns. So remember that every part of the head and face and airway can be overgrown and bossed over. So the face, the tongue, the epiglottis, the vocal cords, and the stretching of the recurrent laryngeal nerve can all be considerations in these patients before we've even done anything with them. We should definitely expect difficult intubation and prepare accordingly. There's a high incidence of hypertension and diabetes in patients who have acromegaly, and they may be at increased risk for entrapment of peripheral arteries and nerves. So for example, you would want to be cautious with A-line placement or peripheral nerve blockade. I'm not going to get into too much more detail about the other hormones that can be secreted from the pituitary gland. I would like to just touch for a moment on vasopressin, which we said is secreted from the posterior pituitary. Vasopressin is responsible for resorption of free water in response to hyperosmolarity. Vasopressin also is a smooth muscle constrictor, and that's why we use it as a pressor in situations of sepsis or hypotension. And vasopressin increases von Willebrand's factor and factor VIII. Now, one of the considerations when patients have surgery on their pituitary gland is the risk of development of diabetes insipidus. Diabetes insipidus can be neurogenic or nephrogenic. Nephrogenic just means the problem is in the renal, in the kidneys, and that's not very common, but more commonly is the neurogenic diabetes insipidus, which is a lack of ADH secretion, a lack of antidiuretic hormone. Patients can develop diabetes insipidus after head trauma, as a result of certain tumors. It can happen after surgery, especially our transsphenoidal pituitary adenoma surgery, or after a subarachnoid hemorrhage. And usually it appears anywhere between 4 and 24 hours of surgery. It can be transient and resolve on its own. And I've had patients go into diabetes insipidus after surgery in PACU. Classically, diabetes insipidus is diagnosed by polydipsia, polyuria, and hypernatremia, as the patient rapidly secretes very large amounts of free water. As a result, the urine-specific gravity is low and urine osmolarity is also very low. And a random serum osmolality tends to be high because of the loss of free water. The classic test is a Miller-Moses water deprivation test, where under very carefully monitored settings, the patients are fluid restricted despite their polyuria and polydipsia, and urine and blood osmolarity can be measured. The treatment for diabetes insipidus is desmopressin, DDAVP, or vasopressin, or carbamazepine. We also want to replace any fluid losses, usually with something like D5 half normal saline, at a rate of maintenance plus 2/3 of their urine output. Patients with diabetes insipidus, if given access to sufficient water, are able to live and survive safely. I also want to talk about SIADH, the syndrome of inappropriate ADH secretion, inappropriate diuretic hormone secretion. The boards like to ask questions about diabetes insipidus and SIADH, so it's really important for you to appreciate the pathologies and the similarities and differences between these two syndromes. So SIADH is really like the opposite of diabetes insipidus. These patients have too much ADH, and so they retain free water instead of pouring out free water. This can occur in response again to head injuries or subarachnoid hemorrhage, also tumors, and particularly small cell cancer of the lung. Drugs that can cause SIADH, the list is very, very long, and I encourage you to look in the books or on the internet if you want to see very extensive lists, but some of the most common drugs that I see popping up again and again are carbamazepine, chlorpropamide, the anti-neoplastic vincristine, and certain antipsychotic agents. Patients with SIADH will develop a dilutional hyponatremia. Remember that when sodium levels get below 110, there's increased risk of CNS toxicity. And they tend to have very concentrated urine. SIADH is often a diagnosis of exclusion once other causes for these metabolic derangements have been ruled out. And the treatment is fluid restriction, plus or minus treatment with hypertonic saline or diuretics. Remember that we want to correct this hyponatremia gradually, ideally by less than half a milliequivalent per hour, and rapid correction of hyponatremia can lead to central pontine myelinosis. We'll pause here for a moment in case you have any questions that you want to write down. Now we're going to skip in your notes to the last section on carcinoid syndrome. This is something that isn't in your textbook, but it does pop up both in clinical practice and perhaps on board exams. And so I just briefly wanted to touch on some of the key points. Carcinoid syndrome is often used as a catch-all term for a number of different vasoactive substances that can be secreted in the body. These include serotonin, kallikrein, histamine, bradykinin, epinephrine, norepinephrine. And most carcinoid tumors are secreted either from the bronchus or from the GI tract, either in the jejunal ileum or the colon or the rectum. And about 20% of the tumors in these areas can lead to carcinoid syndrome. Most of these substances are metabolized in the liver and the lung, like norepinephrine, serotonin, and bradykinin. What do we see in patients who have carcinoid syndrome? Usually it's a sudden onset of flushing, bronchospasm, diarrhea, hyper or hypotension, depending on the substance, and arrhythmias. There's also something called carcinoid heart disease, which is a fibrosis of myocardial tissues, usually right-sided myocardial tissues, as well as tricuspid regurgitation and pulmonic regurgitation or stenosis. In the perioperative period, we especially want to be concerned about carcinoid crisis, which can be fatal if untreated. We may see intense flushing. In the awake patient, we could see diarrhea or abdominal pain. And of course, these substances lead to tachycardia and hyper or hypotension. What is the treatment for carcinoid syndrome? It is somatostatin, also known as octreotide, and this reduces release of vasoactive products. So in patients who are known to have a carcinoid tumor or who are at high risk for potentially having such a tumor, it would be wise to have octreotide available in the operating room or the PACU in case patients have a carcinoid crisis. Most people recommend avoiding drugs that cause release of histamine. Other drugs that they recommend you avoid would be succinylcholine, atracurium, which causes histamine release, epinephrine and norepinephrine when possible, other catecholamines like dopamine, isoproterenol, and thiopental. That's it for this section. We'll stop here and talk about diabetes in the final part of this lecture series.